Hi, welcome back to Coffee Talk with Mike and Janell. We wanted to finish out our little series of side effects from commonly used psychotropics in this population. And today we thought we'd talk about dystonia because it's a very serious side effect and a very common side effect that we see with certain medications such as antipsychotics like Haldol, Zyprexa, and Abilify. And the thing about dystonia is it can be a very mild case to a very severe case.
Mhm.
So I'd like you to describe a little bit about how dystonia presents in a patient and how to identify it, and also what are some of the causes.
Okay. Well, so dystonia in the most general definition is a spasm of a muscle. And there's a lot of different causes. Neurological disorders like Parkinson's, writer's cramp, where your forearm may cramp up, can happen for a lot of different reasons in a lot of different parts of the body. For purposes of today, what we're really talking about is medication-induced dystonia. And as Janelle said, the most common medications to do this are the antipsychotics, and most commonly the older antipsychotics, what we call first generation, Haldol, Prolixin, Thorazine to some extent. However, Risperdal, uh, Abilify, uh, Zyprexa to some extent can also cause these. It really comes down to medications that really block dopamine very robustly.
Okay.
So the way it can present is it can be anything from a mild sense of cramping, like a Charlie horse in your leg, or a tightness in your neck where it feels like your head is pushing over. And often individuals, even though it's happening, they can temporarily move back, but it can go back. But then it can also be very serious. So, for instance, you can get truncal dystonia where it's like your entire back muscles, and so an individual may be really twisted up. And if you think
Like
about,
writhing.
yeah, and if you
Okay.
think about like what it is to wake up with a cramp in your calf or something like that, where it can be really painful, imagine that happening across the entire back of your body. It can be very scary, very painful. This very often happens with individuals who are newly exposed to antipsychotics
Okay.
as well. And so it's a really important thing because when it happens, these are often individuals, if we're talking about psychiatry in general, who maybe have mania or psychosis, maybe paranoid, maybe very hesitant to take medications, and then they have this really bad experience. It can really affect the doctor-patient relationship. And of course, with individuals with autism, IDDD, where they may not be able to actually even express what's going on. There's two types though. These are painful and they're uncomfortable, but there's two types that can be very serious. One is what we call ocular dystonia. So the eyes are,
Mm-hmm.
attached directly to the brain by the optic nerve, and when muscles of the eyes contract the wrong way and they can twist, and often eyes will turn and maybe go in the back of their head, it can actually twist the neurovascular bundle that connects your eyeball to your brain. And if you do that long enough, it cuts off circulation and can lead to permanent eye damage or blindness. The other one that can be incredibly scary is something we call laryngeal dystonia. So it's dystonia of your vocal cords. And if severe, it's very uncommon, but if severe, can actually impair your ability to breathe. So these are things that we really have to always be on the lookout for. Again, they very often happen with rapid escalation of antipsychotics, individuals who may be relatively naive, young, muscled males most commonly are the ones who are
Okay.
at highest risk, but it can really be anyone, even if you've been on antipsychotics for a very long time.
Okay. So we're talking about just like maybe a mild cramp that could probably be tolerated up to something that could be fatal
Correct.
if it's severe where you can't breathe, or you may have vision impairment for the rest of your life if it's not caught. So that's super important with our nonverbal folks for us to be very vigilant and watching for these things. Yes.
Absolutely.
How can we treat this when we identify this as a problem?
Well, similar to when we talked about akathisia or anticholinergic side effects, um, if possible, we try and remove the offending agent. So some antipsychotics are very prone to cause dystonia, and then others far less. For instance, there's very few, if any reports for dystonia from Seroquel, for instance.
Mm-hmm.
So one of it is if we can alter it to a different medication that has less likelihood to cause this. In its acute sense, if someone has dystonia and they're either incredibly uncomfortable or they're having something that is potentially dangerous, as with the eyes or the vocal cords, we give medications that are highly anticholinergic, typically Benadryl or Cogentin. If we can give them by mouth, we will. In a hospital setting, we may give them by injection to relieve this very quickly. And if you recall in our last episode when we were talking about anticholinergic syndrome, sometimes for people who need these antipsychotics, but who are chronically predisposed to dystonia, we actually give them standing doses of Cogentin, which again is very anticholinergic, which we attempt to avoid. But it just comes back to that whole risk-benefit piece. There's no black and white answers here. It is trying to maximize the benefit from a medication while minimizing side effects. But it's really a balance. There is no one right answer.
Right. And every individual is different and reacts different to every single medication. So it really is kind of tweaking it.
Absolutely. And it really just highlights, again, the person writing psychiatric medications, whether they're a psychiatrist, nurse practitioner, physician's assistant, primary care doctor, and the person receiving them need to have open communication about these risks and benefits. And in the case of the ID, DD, ASD population, they should be made actively aware of these side effects to the level that they're able to participate in these conversations.
Yep.
Some are able to do it with they're giving their full informed consent themselves. Often it may be care providers or other people, but these conversations have to happen, particularly for people who cannot verbalize some of these, because families, direct care staff, house managers need to know what the signs are so they can be on the lookout for them. Because again, some of these can be life-threatening or have permanent damage associated with them.
Yes, yes. And that's why it's so important when we do talk about medication trials with patients that the patient, the family, the caretakers, whoever's involved on the treatment team are advised of not only the benefits of the medications, but the potential risks. And we ask them to watch them closely for the next few weeks and to certainly be in touch if they have any questions, concerns, or if something just does not seem right. And I think that's super important. But thank you. I think we covered that fairly well. And I think we're going to change the pace next week and talk about a little more comorbidities with ASD and possibly bipolar, sir?
Absolutely. And
right.
We just need to remember, I mean, we've been focusing a lot on medications more recently and medication side effects. That won't be the topic of every coffee talk with us. But medications can be really important. They're only part of the treatment plan.
Absolutely.
They are not a definitive treatment plan, and they're part of the larger
equation.
Behavioral, educational support for families and individuals, and they all have equal importance.
Yes, it's important to look at the big picture because there's so many different variables affecting these folks that we need to be mindful of.
Absolutely.
All right. Well, until next time.
APEC out.
APEC out.